Okay, we are back. Our coverage continues at HIMSS today. We have John Elliott, who's the president and CEO of ChartWise. Now, this is a great company. This is your second company, but I assume
Yes.
today this is mostly what you want to talk about.
Yes, that's fine. So not too long ago, Medicare changed the way they reimburse hospitals. And with those changes, reimbursements went down to hospitals. And there's been a big scramble to do a better job of documentation. Mm-hmm. If you do a better job documenting, the reimbursements can be restored. So that was the premise behind starting the company.
Okay. Now, a lot of vendors here, a lot of electronic medical record companies have, they have a lot of check boxes for you to, try to bill more in the review of systems and your physical exam and your procedures, lots of things you can check off and maybe improve things. But how does ChartWise approach this problem?
Well, I want to start back about a year and a half when I'm sitting in a hospital auditorium getting a lecture from a very well-meaning consultant who's saying, doctors, you have to do a better job with your coding, because if you don't, we're not going to get reimbursed, and you have to do this. And they start to show a note, and it looks like a wonderful note to me. Mm-hmm. And he says, no, this is not adequate because you need to say these other things. And after a little while, I said, man, he's asking me to be conversant in 17,000 codes. Mm-hmm. And I'm very smart, or as we say in Rhode Island, wicked smart, but I'm not that smart.
Another New Englander.
So I said, there's got to be a computer program that helps me keep track of all that. That was the inspiration for starting with ChartWise.
Okay. I don't know if you've seen, there's some parodies online about like what a great chart would actually look like in the eyes of the coder. And it'd be like, the patient walked to the bedside and did not express any distress and sat down without any difficulty. And there were no objects protruding from this patient's abdomen and things like that. I hope that ChartWise doesn't make the chart illegible or so laden with details that it's hard to interpret.
So first of all, the chart is illegible in its current state with the physician's handwriting, although I do a pretty good job of that, but it is very targeted. One of the problems is that if there's things in the lab data, an echo report, the coder can't use that. They can only use things provided by the physician in the physician's note. And it's one of the biggest sources of loss of reimbursement for the hospital. So we are able to take that information out of the chart, translate it into a very small note. The entire report, if I really go crazy with it, is still less than a page. But it has the evidence in there, very extreme documentation, and it provides a very cool audit trail from the initial documentation to the enhanced documentation, the queries that went into it, the evidence that's behind it. So it's very defensible and auditable.
Okay. So let me ask you, does ChartWise interface with existing EMRs? Does it replace them?
I would think, I'm paraphrasing an old commercial now, we don't make your EMR, we make your EMR better. Okay. So it does come in. It is not a standalone EMR. The product that we've announced and released today is a hosted system, so it's web-based. You don't need a big computer system. In fact, any computer system in your hospital. If you have 0 computers, you could go ahead, and if you had a PC or a Mac with a modern web browser, you could start using our system.
Okay, so it doesn't require doctors to change their systems or hospital administrators to change their systems. They install it, and then how do they see the results? Do the coders see the results? How does this benefit get appreciated?
Well, I've been a physician since 1975 when I graduated from medical school, and in all of that 35 years, I have never once seen a chart after it's been coded. It's magic to me. It goes off to the coding department. I never see it. And we are really striving as an industry to get to concurrent coding, where the coders are seeing the information, the chart, the kinds of things that we're saying before it gets to them to allow additional physician input. Now, I've had a couple of scares personally as I'm trying to work through this system. For example, as a cardiologist, I often have a diagnosis of unstable angina. What's the ICD-9 code for unstable angina? There isn't one.
There's like 500.
It turns out the closest code is intermediate coronary syndrome. Oh. Well, it was archaic in 1975 when I graduated from medical school, and it's still archaic. There is no code for non-Q-wave MI, for non-transmural infarct, for subendocardial infarct. These are clinical terms that I want to use, and there's no coding equivalent. So there's this huge divide between clinical documentation and diagnostic documentation. And that's the place where ChartWise CDI bridges that gap.
Okay. For a moment, I thought you were going to say, I have seen some of my older charts that get marked up by the coders, and it's amazing. When I have a chest pain patient that's diaphoretic, they end up with a diagnosis of hyperhidrosis, which is codable, and our coders go for it. But it doesn't sound like that's what ChartWise is doing. Instead, it's trying to intelligently interpret doctors' diagnostic terms into ICD-9.
Yes, let me give you another example. I've used the term congestive heart failure, as have you, for a long time. Congestive heart failure is not considered a complication. Acute systolic congestive heart failure is.
Okay.
I've never used the terms acute systolic heart failure. I didn't even know what it meant until I started running across this. So they're asking me to be a coder when I write my note, and I don't think that's fair. So the ChartWise CDI is trying to say, go ahead, be clinical. Speak in your clinical terms, and we'll enhance that, provide you the adjectives that you might provide. Think of it as a little sage wizard sitting on my shoulder, whispering in my ear, saying, psst, there's a couple of types of heart failure. What do you want to say?
Do you customize your interface for different specialists, for different kinds of doctors, or even doctors within the same specialty that tend to use different lingo?
No, this covers the whole waterfront. I took a log of my patients in the coronary care unit for a week. And you'd think they'd all be cardiology patients. They had strokes and renal failures and pneumonias and neurologic problems and GI problems, and they covered the whole gamut. So they're really, for most medical situations, it's rare to have just an isolated organ system.
Okay. And I gotta ask, like, what kind of benefits are you seeing in terms of like, are you able to chart up to a level 5 on something that would have been like a level 4 before, or are you able to get reimbursed for procedures that otherwise wouldn't be noticed?
So an important distinction inherent in that question, the E&M coding, evaluation and management coding, would be the kinds of things that you'd be referring to, which is the physician reimbursement. Yeah. This is helpful for the hospital side, for the hospital reimbursement. And let's face it, hospitals are struggling with all the uncompensated care that's out there. Good hospitals are running at a 0 or 1% margin, and they need every little bit of help that they can get for improving their reimbursements.
Okay. Sure. Hey, I'm going to throw it over to Dr. Val, who's monitoring our chat room.
They're they're chirping away about how much they're enjoying this interview and the energy that you bring to the conversation, and they're like, "I like this guy." So that's not a question so much as a comment, but one word: ICD-10.
A one-word question, I love it. So there's 17,000 codes in ICD-9, and if I'm having trouble keeping up with those, what am I going to do on October 1st, 2013, when that number goes up to 317,000? Just parenthetically, as a cardiologist, there is one code for coronary angioplasty in ICD-9. In ICD-10, there are 1,700 codes for angioplasty. So you can imagine this has a number of people worried. Our system runs over ICD-9 or ICD-10. So it was one of the things that we planned for when we designed ChartWise CDI, is that it doesn't care what coding system it runs over. So on October 1st, 2010, I look forward to flicking the switch and simply changing the coding system. It will not translate from 9 to 10. It doesn't need to. What's important is what coding system is in effect the day the patient is discharged. That's what drives the billing. So I don't need to do that particular translation, but it's independent of the code system that's under it.
My goodness, this ICD-10 sounds more daunting than I imagined.
I don't want to leave that thought. I love ICD-10 because I talked about the fact that what is the code for unstable angina? There isn't one. ICD-9 is very archaic. It's been patched. There is one code for HIV. There are pages and pages of codes for tuberculosis. It's very out of date. So ICD-10 brings some rationale, extends it to the practice of modern medicine. So while it's onerous in its numbers, it's needed.